Good evening, everyone, and welcome to this PET event. Lifestyle, obesity, diabetes, optimising IVF outcomes for patients. It's great to be in Scotland, and it's great to be thinking about this topic because in Scotland there is great access to fertility treatment on the NHS. It's the best in the UK. And the people seeking it, we want to optimise the outcomes for them. We want, them to have the most straightforward pathway. We don't want them to have to come back multiple times. Obviously they can, they're unsuccessful, but that's not the goal. The goal is to give them a baby. But as is across the UK, there are access criteria to qualify for treatment on the NHS. So the prospective birth mother must have a BMI above 18.5 and below 30. Both partners must not smoke, vape or use nicotine for at least 3 months before referral for treatment, and couples must continue to be non-smoking throughout. Alcohol and drugs. Both partners mustn't use illegal and abusive substances, and neither partner should drink alcohol prior to or during the period of treatment. And then, of course, age. If a couple is referred for IVF or ICSI, treatment where the intended mother is aged 39, then the couple are unlikely to receive more than one funded cycle. Whereas couples where the intended birth mother is over the age of 42 will not be eligible for NHS-funded treatment. And as Professor Bhattacharya at the University of Aberdeen said at a previous PET event, the offer of NHS-funded fertility treatment can be a great motivator for some people to go on a health kick, to try to lose weight and to give up smoking. It can help incentivise them. But we all know it's difficult. And when thinking about optimising patient outcomes, the last of the criteria that I mentioned, age, is probably the most significant in terms of a successful outcome, as advanced maternal age in particular can reduce the chances of success and increase the risks to the woman during pregnancy and delivering the baby, and as well as to the baby. And that is why across the UK we have strict age criteria. But age is something we've covered quite a few times over the years at PET events. So tonight we're really focusing more on the other access criteria, although I'm sure that age will creep in because it has a habit of doing that. So we're looking at underlying health conditions such as polycystic ovary syndrome and diabetes. So our first speaker tonight is Dr. Tony Nicol. He's the Senior Medical Officer for Maternal and Women's Health for the Scottish Government.
I've been a consultant for 20 years or so almost, and I have a special interest in managing women with high-risk pregnancy, including women with obesity and women with diabetes. I was within NHS Tayside the lead for the maternal obesity service for a number of years before taking on my role within Scottish Government. I've been given the task to sort of set the scene, and I guess it's what happens if you don't optimise care for women with obesity and diabetes. And just to describe, really to set the scene for this evening, what can happen if you have poorly controlled diabetes, or what the risks are for pregnant women with obesity. In order to sort of, by means of introduction, it's just to give you an idea of the scale of the problem. It's estimated that around about 1 in 175 women have pre-existing diabetes, that is type 1 and type 2 diabetes. I think within Scotland it's slightly higher than that. The latest birth statistics that you can see on the right-hand side of the screen there put the prevalence of pre-existing diabetes about 1 in 100 or so. And you can see just in that top graphic on the right-hand side of the screen, the bottom line, the bottom blue line, is the rate of diabetes, and we can see that that's increasing. And the top line is the rate of obesity, which is also increasing. For those women with pre-existing diabetes, most of them are type 1 diabetics. There's another condition. The majority of women with what we call diabetes in pregnancy are those with gestational diabetes, which affects about 10% of pregnant women. Gestational diabetes is a condition where women have a resistance to insulin. Well, all women have a resistance to insulin in pregnancy, but a number of women will have higher levels of glucose, and that's associated with pregnancy-specific complications that we'll talk about later in this presentation. So that's diabetes. Obesity is also, as I said, increasing in prevalence. And now within Scotland, 25% of women have a body mass index of greater than 30, what we classify as obesity. The bottom graphic here shows the impact of healthcare inequalities, and we can see that the rates of obesity within the pregnant population range from 20% in the least deprived areas to over 30%, nearly a third of women in the most deprived areas are obese. And this population also is more likely to have higher rates of diabetes as well. And there is a degree of overlap between diabetes and obesity, which you'll get from this presentation, hopefully. We know that in adults, those with type 1 diabetes, about 2/3 of them are obese, and those with type 2 diabetes, almost 9 out of 10 of them are obese. So that's setting the scene. It's a common problem. Both of these conditions are common problems, and both of these conditions have a significant impact on maternity services. When I look at medical problems in pregnancy, the way I look at medical disorders such as obesity and pre-existing diabetes, we look at it one way. We look, what does pregnancy do to the women with that condition? How does it affect the condition? And then we look at it and say, well, what does the condition actually do to the pregnancy, and what are the outcomes, the adverse outcomes caused by the condition? So I guess that's the way I'm going to structure my talk. So this slide here shows what the maternal risk, what happens to the women with obesity, and what happens to the women with diabetes, what are the specific pregnancy risks. So for obesity, well, every woman will gain weight during pregnancy. The average weight gain in pregnancy is about 10 to 12 kilograms. And so women who are obese will also gain weight. And that could be significant because it may tip them into another weight category. It's got implications for the medication that we prescribe in pregnancy. They may need a higher dose of medication because their weight has increased, thinking about thromboprophylaxis. It also has implications for, in the third trimester of pregnancy, when we're thinking about managing the labour and birth. The increase in weight may take them over a threshold that they're too big for the standard maternity beds that we provide, too big for the operating tables that we provide surgery on. So it's important to be mindful of this, and the recommendation are that for women with obesity, the recommended weight gain is lower, perhaps in the order of 5 to 9 kilograms rather than the 10 to 12 kilograms that the average pregnant woman will gain. We know that women with obesity are at increased risk of cardiovascular complications, and these complications may increase in pregnancy, namely hypertension, and perhaps ischemic heart disease may be more common in the obese population because of the increased cardiovascular stress that's associated with pregnancy. Pregnant women with obesity are more likely to develop this condition called gestational diabetes. They've got about a 2 to 3 times increase in risk compared to the background population risk. And also women who have obesity are at increased risk of other complications, for example, pressure sores due to immobility, particularly towards the end of the pregnancy, and if they've had a surgical birth, for which they're more at risk of. For women with pre-existing diabetes, both type 1 and type 2 diabetes are at risk of a number of complications. So pregnancy can, if you develop hyperemesis, for example, your insulin requirements may not be so high, so you may develop hypoglycemia. Women with type 1 diabetes in particular are at risk of the other complication, which is diabetic ketoacidosis, which is a life-threatening complication where you've got high levels of glucose and then you produce ketones and you develop a metabolic acidosis, which could be life-threatening not only for the mother, but also for the unborn baby. Women with diabetes are at increased risk of infection. Now, these may be minor infections like urinary tract infections, or they may be more significant, such as life-threatening chorioamnionitis, that's infection within the womb. These are the complications of diabetes that we can see in the non-pregnant population, and pregnancy can increase accelerate the incidence or the prevalence of these complications, whether it's kidney disease or nephropathy, or eye disease such as retinopathy, or vasculopathy such as foot disease that we see in diabetes. So we need to monitor women for these complications developing during pregnancy. Coming on to what the pregnancy risks are, so we can think of early pregnancy, mid-pregnancy, late pregnancy risks, then labour and birth. So if we think about the early pregnancy risk, Women who have a body mass index greater than 30 have a 50% increase in the risk of spontaneous miscarriage. About 10 to 20% of all pregnancies end in miscarriage, but women with obesity and diabetes are particularly vulnerable to these early pregnancy losses. Recurrent miscarriage is where you have successive miscarriages, and women who have a BMI of more than 30 have a 75% increase in the risk of recurrent miscarriage. And it's the same, the numbers are similar for women with pre-existing diabetes. So a 25% increase in the risk of miscarriage and a 73% increase in the risk of recurrent miscarriage. I'd just like to draw attention to, we recognise this when the Scottish Government published earlier this year a framework for miscarriage care in Scotland, and within that we do draw attention to the fact that women with obesity and women with diabetes are particularly vulnerable. And this, although this document is set up to care for everyone, it does suggest lifestyle modification and ways that you can potentially reduce the risk for women with obesity and diabetes. We're moving on to the mid-trimester of pregnancy now. And in the mid-trimester of pregnancy, the main thing that happens to, or one of the things that happens to women is women receive a scan to assess the development of their unborn baby. And we know that women with diabetes and obesity are at risk of problems developing in the unborn baby. So on the right-hand side of the screen here, I've got some ultrasound images. The bottom one there is an early pregnancy image of a healthy baby. But towards the left-hand side there, that's a fetal heart with an atrioventricular septal defect. And the top image there is a horizontal view of the baby, and you can see the baby's back there. There's a cystic mass on there. That's something called a spina bifida. So women with diabetes and obesity are at risk of a number of different congenital problems, and I've just highlighted two of the most common congenital problems that we see within fetal medicine. That is cardiac disease and spina bifida. The magnitude of risk for women with obesity, it's probably double the risk compared to the background population risk. So we think about 1 to 2% of all women have a baby with a congenital problem. With obesity, you're doubling that risk. But for specific problems, and I draw your attention to the spina bifida line there, which is the second line in that table, the risk is about just 2.24 times. And that level of risk is comparable to women with epilepsy who are taking anti-epilepsy drugs, which we know are teratogenic. So it's a significant risk for these women. With women with diabetes, the risk is somewhere between 1.5 and double the risk of the background population risk, but the risk is related to your glycemic control, or your glucose control, I should say. So that the worse your glucose control is, the higher the risk you are of having a baby with a developmental problem. What I would say is that for women with high body mass index, the challenge is identifying these. These are really, forgive me, but these are nice ultrasound pictures where the abnormalities are quite clear for those of us that work in fetal medicine. However, if you can imagine you've got a foot worth of adipose tissue to send your ultrasound beam through, your images will never be as clear as that, and that's the real challenge, that these women are at high risk of having congenital conditions, but the challenge is identifying those. Coming back to the early pregnancy risk, there's other conditions that we screen for earlier in pregnancy, that is Down syndrome and other chromosome conditions, such as Edwards syndrome and Patau syndrome. And the way we assess that risk is measuring the little fold of skin, or fluid, I should say, at the back of the baby's neck that you can see just to the bottom, the little black area between the baby and the skin there. And we measure that in the first trimester and combine that with hormone markers to give us a risk of that woman having a risk of a baby with one of these three conditions. This is again challenging in women with obesity, and most of these women will not be able to complete first trimester screening and will then have to have second trimester screening. So again, it's another risk in pregnancy that we may not be as effective in identifying some of these conditions in women with obesity. And we're moving through pregnancy and getting into the third trimester. So I was going to talk about obesity in one slide and diabetes in another slide, but there's so much overlap between the two. I just want to highlight some of the things that we might see, or I might see as an obstetrician when I provide care for women with diabetes and women with obesity. So the main risk, I guess, is hypertension and preeclampsia. Preeclampsia is a pregnancy-specific condition that's associated with high blood pressure, and it can affect multiple different systems, whether it be your liver function, kidney function, but it can also affect the health of the baby by affecting placental function. So women who are obese have a 4 times increase in risk in hypertension or hypertensive disease in pregnancy, and women with diabetes have a similar level of risk. We tend to associate obesity and diabetes with having a large baby, which we call macrosomia, but actually if you've got more severe disease, you're more likely to have placental dysfunction, and you may in fact have a growth-restricted baby. It's important to be mindful of that, because you may see a baby that's in an average range when you're plotting it on a chart, but that actually for a diabetic woman or for an obese woman might potentially be a growth-restricted baby, so you just have to be careful for that. We know that women with obesity and diabetes are at high risk of preterm birth. That might be iatrogenic or clinician indicated because we're worried about some of these complications, but there are also increase of spontaneous preterm birth, mainly due to macrosomia, or this condition called polyhydramnios, where you have excessive fluid around the baby, which may trigger preterm birth, or it may cause the baby to lie in an unusual way, with either coming foot first, bottom first, or lying across the way. I will speak about the increased risk of stillbirth on the next slide, but just thinking about other neonatal or fetal risks, I mentioned preterm birth, but babies that are born to women with obesity and diabetes are more likely to have lower sugar levels after birth because they've been in an environment with high insulin. They're more likely to be jaundiced. They're more likely to develop respiratory distress because of delayed fetal lung maturation. And not only is the risk of stillbirth there's also an increased risk of neonatal mortality in these babies. Coming on to stillbirth, we know that the risk of stillbirth in women who are obese is about 2 to 3 times higher than the background risk. In Scotland, the risk of stillbirth is about 3 per 1,000 at the moment, or roughly 1 in 2 to 300. With women with diabetes, again, it comes back to your diabetes control. The higher your the worse your control, the more risk there is of stillbirth. And the way we monitor control is measuring something called your glycosylated hemoglobin, or HbA1c. And we can see in the table there that the higher your HbA1c in both type 1 and type 2 diabetes, the greater your risk of pregnancy loss. So in general, for type 2 diabetes, your risk is about 7 times higher than the background risk. For type 1 diabetes, it's about 5 or 6 times higher than the background risk. A high HbA1c is also correlates with an increased risk for women with diabetes for macrosomia, hypoglycemia, neonatal respiratory morbidity, and a low APGAR score. APGAR score is a score that we give to babies when they're born to assess their well-being. This risk is not only increased for women with pre-existing diabetes, but also increased for women with gestational diabetes. But with women with gestational diabetes, if you screen for and identify their gestational diabetes and treat their gestational diabetes, you can mitigate that risk and bring that risk down to the background population risk. And that's the same for pre-existing diabetes as well. The aim is to lower that risk by improving and controlling their blood sugar levels. Coming on to labour and birth, women with diabetes and women with obesity are at risk of complications in labour and birth. We mentioned preterm birth. There are higher rates of induction of labour, higher rates of prolonged labour. With women with obesity and diabetes, the uterus will behave differently, and the mechanisms of labour are affected. And so on average, for obese women, your labour tends to be about 1 to 2 hours longer if you do have a labour. The majority of women who are obese or have or have diabetes will have their baby by caesarean section. The caesarean section rate in Scotland is about 40 to 50% at the moment. And in fact, the latest statistics showed that more babies were born by caesarean section in Scotland than were born by a midwife by vaginal birth. And that's a trend that has been continuing over the last 5 years, and it's just going higher and higher. And it's a challenge for us within maternity how we address that. If a woman does have a vaginal birth, she's at risk of complications from that, whether the baby gets stuck because the shoulders impact against the pelvis. That's a condition called shoulder dystocia that is potentially life-threatening for the baby. The mother is at risk of trauma to the perineum during birth. Both mothers with diabetes and obesity are at risk of bleeding after the birth of their baby, which is postpartum hemorrhage. And as alluded to earlier, the surgery for women with obesity is more challenging, not only for the obstetrician delivering the baby, but also for the anaesthetist providing that anaesthetic. I'll just gloss over how we manage women with obesity and diabetes at the end of pregnancy. There are also postnatal risks. The risk of maternal mortality is about 1 in 10,000, but we know that women with diabetes and women with obesity are at greater risk. And the leading cause of maternal mortality is venous thromboembolism. That's clots in the legs, clots in the lungs, and this is the leading cause. About 37% in the last report of the confidential inquiries published by Embrace were associated with obesity. Obese women have higher rates of mental health problems, with depression seen in about a third. Obese women have lower rates of breastfeeding. For both these groups, they have a lifetime risk of type 2 diabetes. And so if you develop gestational diabetes, it's estimated that about 4 out of 10 women will develop type 2 diabetes within 10 years. And these women are also at risk of long-term cardiovascular complications, ischemic heart disease and hypertension in later life, as well as future pregnancy risks, as well as risks for their babies. I guess just to finish up, I'm just setting the scene here, and I don't want to be too negative because it's important to keep in mind, although these women are at high risk, we're here as a maternity service and as a multidisciplinary service involving endocrinologists, specialist nurses, specialist midwives to try and reduce that risk. I guess we'll hear later about ways that we can reduce that risk, but just we as obstetricians like to see these women before they become pregnant so that we can take steps to try and mitigate that risk. So we try and optimize glycemic control, try and advise women to lose weight by adopting a regime of exercise and having appropriate diet. But we also think of other healthcare advice to try and optimize outcomes such as stopping smoking, avoiding alcohol and drugs. And one of the things we can do to reduce the occurrence of spina bifida, which I highlighted earlier, is to take a high dose of folic acid. A 5 milligram tablet, if it's taken 2 months before pregnancy, will reduce your risk back down to the background population risk. And I know I'm at a fertility meeting, but I can't leave without mentioning contraception. If a woman is at high risk, for example, if she's got an HbA1c that's above 86, for example, in the higher end, then that woman should be advised not to get pregnant, and you need to try and make every effort to try and stop that. So we will have a discussion about contraception.
So we shall move on now to our next speaker, Rebecca Reynolds. Rebecca is Professor of Metabolic Medicine at the University of Edinburgh's Centre for Cardiovascular Science. She's an honorary consultant physician at the Royal Infirmary of Edinburgh and at Western General Hospital, and she's founder of the Lothian Metabolic Antenatal Clinic. Rebecca is a contributor to books including Obesity and Gynecology and Maternal Obesity and Pregnancy.
So we've had a really good introduction to the scale of the problem for people who do enter pregnancy when they are overweight and obese or have diabetes in pregnancy. So what I'm hoping that I'm going to talk to you about is some of the ways that we can intervene to help that in planning pregnancy. And again, setting the scene, unfortunately, you do see news headlines like this quite regularly around the staggering rates of obesity amongst children and adolescents in the UK. And in Scotland, unfortunately, our statistic around adolescents who are overweight and obese is the worst in the whole of the UK. So we have the highest rates of obese adolescents, particularly in women. And of course, they're going to be the next generation who are going to be entering pregnancy. So can we really use that pre-pregnancy time as a time to focus and help people to lose weight in order to allow them access to fertility treatment if they need it, or in order for them to have a more healthy pregnancy if they don't need the fertility treatment? And generally, women are very motivated to optimize their health when they are pregnant. We know people give up smoking, for example, they give up alcohol. So can we also get them to think about losing some weight? So if you look at the guidelines around the world, then actually there's 5 international maternity societies from the UK, Australia, Canada, and they all recommend that people should enter pregnancy at a healthy weight. So women entering pregnancy trying to get their body mass index, which is the way we assess obesity, under 30. But none of these guidelines specify how much weight people should lose, when they should lose the weight. They say that you should have lifestyle changes with diet and exercise, and actually currently only one of the guidelines, and that's the guideline from Canada, suggests that you might consider to use weight loss drugs. So really, they're all saying, yes, you should do it, but they don't say, how should you do it? We do know that there have been quite a number of studies of lifestyle interventions, and they've mainly been done in the context of people who are seeking fertility treatment, so attending fertility clinics. And arguably, they may be a slightly more motivated group because they know that if they can lose weight, then they can access the treatment. As we heard today, you need to have a BMI of under 30. So this is a study where they pulled together the evidence from 16 studies in women with infertility, so it included just over 3,500 women. And they found that women who were randomized to a weight loss intervention were more likely to become pregnant, so 24% more likely to become pregnant. But actually in this meta-analysis, when they pulled all the data together, they didn't necessarily go home with a baby. So the confidence intervals just crossed the null, so it wasn't quite significant. So what kind of interventions would the lifestyle interventions be? Does it matter what you do? Well, again, this was another study where they pulled together data from a number of different studies, both trials that had done just diet interventions, diet and exercise interventions, studies that were non-randomized but still given those interventions, and then studies that had included extra things like motivational interviewing, so trying to give people extra help to enable them to stick to the lifestyle intervention. And what you can see is that all the green and black boxes on the left of the vertical line are all on the left side of this chart, which suggests that they are causing weight loss. So all these interventions, no matter what you do, were associated with a roughly 4 kilogram weight loss, which in the grand scheme of things maybe doesn't sound like a huge amount of weight. So if you think about if somebody's very overweight, so we do a clinic for women with a body mass index of over 40, they weigh on average 120 kilos, so maybe a 4 kilogram weight loss is not a huge amount. Oops, going the wrong way. So the challenge is also, how are you going to implement and resource this? All our NHS services are really stretched, so how can we spend the time and energy to get people to be enrolled in these programs to help them weight loss? And also the other challenge is, how can you raise awareness among women that if they have a body mass index of over 30, that is actually potentially dangerous for their pregnancy? Because many women have friends who've got pregnant at that weight without any issue at all, and they really don't see that it's a problem. In a clinical trial that we did where we were offering people treatment if they had a BMI of over 30 in pregnancy to help them win their pregnancy, the main reason for not taking part was because they didn't perceive to have a problem, which is something that we need to try and address. So what about the alternatives? Well, there have been quite a number of studies done where people have been offered bariatric surgery. So surgery where the stomach is reduced in size in order to minimize the amount of food that you can eat. And then they've gone on to look at women who have pregnancies following this. And whilst there are some benefits of having bariatric surgery, actually because the women don't eat so much and can't eat so much, they do have complications in pregnancy, including increased risk of having a baby that's born too small or a baby that's born preterm. And that particularly can happen if women get pregnant in that period of very rapid weight loss that they have immediately following bariatric surgery. So the latest thing is, what about weight loss drugs? And there's been a number of interest and headlines now about so-called Ozempic babies, with reports like this. Reports of surprise pregnancies raise new questions about weight loss drugs. And almost every day that you go onto the news, there's some benefit of being on a weight loss drug, whether it's depression, it's cancer, but now it's potentially pregnancy. And this is an area of concern because actually there's very little evidence. I'm going to show you what evidence there is. So there is actually now a Facebook page, hashtag Ozempic Babies, where women report their experience of being on these drugs and going through seemingly healthy pregnancies. And this is just because, of course, people are able to buy these drugs now over the counter, and sometimes they don't even know exactly what they're buying. And actually, this slide is probably out of date now because Ozempic is now considered to be less good than the new drug Mounjaro, which is a more complicated drug and does have a bigger weight loss effect. So what is the evidence? Well, currently there is really very little evidence of the safety of these drugs in pregnancy. So the FDA, which is the American board that assesses drugs, says that it's unknown if these drugs, they're called GLP-1 receptor agonists is their name, unknown if they will harm your unborn baby. So that's quite stark advice. And so currently the recommendation is that the drugs should be stopped at least 2 months prior to conception. That's based on how long it takes for the drug to get out of your body if you're taking it. So the half-life is when half of the drug will have gone away in 5 to 7 days, and then another half will have gone away in another 5 to 7 days. So 6 to 8 weeks, so 2 months before, and so women should be encouraged to use contraception to prevent unintended pregnancies. And I know that this is not happening because I saw a patient in my clinic last week who'd bought this drug. She was actually a lady with polycystic ovary syndrome who bought the drug, and the person that sold it to her said you can take it right up until you're pregnant. So this information is not getting out there. However, if you do happen to become pregnant when you're taking these drugs, so far the data suggests that there maybe is less harm than we might expect. The problem is we don't really have good data because often these drugs are just purchased over the counter and we can't really find out therefore who's on them. So there has been a so-called database study from 4 Scandinavian countries, the United States and Israel, and they found that if women had been taking GLP-1 receptor agonists in the first trimester of pregnancy, there was no evidence of congenital malformations or any evidence of cardiac malformations, and no evidence of any kind of miscarriages or anything like that. But the number were really small. There were only about 75 or 80 of these complications in the whole data sets. The other, I guess, kind of thing that we don't understand is what happens to gestational weight gain. So these drugs work by switching off your appetite. People who are very overweight and obese have this so-called food noise, which means they just constantly want to eat. And when they take these drugs, that just goes away and they don't feel hungry. But when they stop the drugs, that comes straight back on again. So we don't know if they then have the double whammy of stopping the drug and then becoming pregnant, will they gain potentially even more weight than they would have done if they hadn't been taking them. And there's just been one case report from America where they suggested that people who'd taken these drugs and then stopped them had greater gestational weight gain. So we need to understand how to use them if we're going to use them. And then when we come on to the animal studies where they've used them in pregnancy, then there is potentially some adverse effects that could cause concern. So mothers eating less food, mothers gaining less weight, and then potential for adverse offspring effects. So babies being born small, and then skeletal, so bone abnormalities. And this, of course, is a major risk, and we certainly wouldn't want to have that in pregnancy. So do they cross the placenta? They're quite big molecules, so it's thought that they don't cross the placenta, but in the animal studies where the placentas are slightly different from humans, then there is some evidence that it does cause interference with the way the placenta works, particularly the way the blood vessels work with it, and presumably, therefore, how much nutrients can get through to the developing baby. So I think there's a lot of uncertainties. The animals' evidence suggests that they've got potential adverse effects for the offspring. We don't really know enough about how they work and how the metabolic benefits of taking them and losing weight, whether they'll be sustained in pregnancy. We don't know how much weight loss would be important for women. And also, importantly, if people lose weight very rapidly, they can also lose muscle mass, so not just fat mass. And again, that might not be associated with the best outcomes for pregnancy. So we've got a lot of work to do. And also in our diabetes clinics, we have the option of giving people weight loss drugs because they have obesity and diabetes. And that can often mean they can come off a lot of their diabetes medication. But then we need to be really careful when they enter pregnancy because they might need to rapidly go back onto diabetes medication to ensure their pregnancy is safe. So the challenge we have with any of these pharmacological or drug treatments is that we need to be thinking of it, when we're giving an intervention, we're not only intervening on the mother, but we're also potentially intervening for the child. So we want to have a treatment for the mother that's convenient, that she tolerates well, that leads to less gestational weight gain, better health for her next pregnancy, less risk of later life obesity and diabetes. But importantly for the pregnancy, that intervention should not have any adverse effects for the child. And that's where the challenge in this weight loss drug arena is, I think. So we do run a metabolic antenatal clinic in Edinburgh for women who have a body mass index of over 40, and many of the approaches that we've taken in that clinic have been put together in a guideline for clinicians in how to manage obesity in pregnancy, and that's currently being upgraded with the most recent literature. And of course, you know, pregnancy, when to intervene, there's lots of different windows. The challenge of trying to identify people preconception is that you don't know who they are. They don't turn up at a clinic, you can't identify them. So maybe the time we need to be thinking about is that postpartum time, so that inter-pregnancy interval, preparing for the next pregnancy. What we're really trying to do is prevent this kind of intergenerational cycle of obesity where a mother who's obese or has diabetes in pregnancy has a baby that's born too large. If there's no intervention, they grow up to be a child who has obesity, and then an adult who has obesity and type 2 diabetes, and then they potentially enter the next pregnancy. So we perpetuate through the generations. I just wanted to highlight the UK Preconception Partnership. So if any of you are interested in working in this space, this is a national network of people who are interested in improving preconception health. And we have a network in Scotland. I'm co-lead it with a colleague in Stirling. And we'd be very welcome if anyone wants to join the network. We have fairly informal meetings to discuss how we can work together, and also how we can work with the Scottish Government to really raise awareness of preconception health as a really important time for intervening to improve outcomes for both mothers and children. And thank you very much for listening.
We have now for you Colin Duncan. Colin is Professor of Reproductive Medicine and Science and Principal Investigator at the University of Edinburgh's Centre for Reproductive Health. He's a subspecialist in reproductive medicine and surgery at the Edinburgh Fertility Society, and he's a contributor to books including Obesity and Gynecology and How to Prepare the Egg and Embryo to Maximise IVF Success.
So we've heard that the NHS doesn't fund people who are obese to become pregnant through IVF. So there's a BMI limit of 30 for the female partner. Okay? And I want to start off by saying what my understanding about what obesity is. Obesity is a chronic, relapsing health condition. Obesity is not a choice. People don't choose to be obese. And most women who are obese are not infertile. And I think that's the first things I wanted to highlight. But we've talked about how obesity is something that's bad and how can we help people with obesity. So here we are. This is successful weight loss after interventions for a year. Okay? Now, this is the intervention that we recommend. You've heard about the recommendations. So here we are, lifestyle modification. So in that, weight loss, where do you think a year's worth of lifestyle intervention gets us? Go on a diet and exercise. Down there. Medication, that's that. And then the stomach surgery we've heard about is up there. Okay? So the things that we say to patients to do is not that successful. And one of the other things to sort of think about is not all women with obesity are the same. Here's women with obesity and women with obesity, living with obesity, who have polycystic ovary syndrome. And what you're seeing is that those with polycystic ovary syndrome are in the white squares, and those that are weight matched are in the black diamonds. And this is the energy you expend after eating. Okay? You're sitting somebody in a room, putting a big hood over them and measuring their burning off of calories. And guess what? People do it differently. And if you don't burn off and there's not enough calories, you're more likely to struggle to lose weight. Because people are different. And things that are quite interesting is there's a memory of obesity. Okay? We heard from Rebecca saying that there's this noise going on in the head. And here we are. This is the drug. This is Ozempic. And what you can see is it's amazing. Absolutely amazing. And people have got down to a weight that they're really, really happy with. They are where they want to be. And then they stop it. And it goes back up again. And there is a memory of obesity. And there's this great study that was published in Nature just last year. So what they did was they got somebody with an increased BMI, or a group of people with an increased BMI, did the stomach surgery. They got to a normal BMI. And then they compared them with somebody of a normal BMI, and they looked at their fat. And they found that the fat signature was that of a fat person rather than a thin person. When they looked at it, sort of looked at what that function of the fat was. And they thought, that's interesting. And what they did was they got sort of a mouse, the fat mouse, and they put it on a diet until it was the same as a normal mouse. And so the fat mouse this is a mouse that was made fat by giving it lots of food. And then what happens is they give it a normal diet, and then the mouse lost weight, because it's a normal mouse, and it lost weight. But it's got a memory. And they looked at the fat, and the fat in that mouse was just as different as the fat in the fat person who'd lost the weight. And therefore, what they did was they gave it, right, let's give lots of food and see what happens. And guess what happened? There was a memory. And so from the same weight, that mouse had been programmed that with the same amount of fat to gain more weight. So we're very good at memorizing obesity, and that's why it's a chronic relapsing condition. And what we can say is we say to our patients that we won't treat you because what we have to do is get your weight down. But we're not very good at doing that by saying go and diet and exercise, and that's what we do. And so why do we do that? Okay, well, in an IVF, let's look at IVF. This is, so I've done exaggerated slides here, but the crucial thing is let's look at the risks of doing IVF if you're obese. So if you're obese, it takes you longer to do IVF. You need more drugs to do IVF. You're more likely to get cancelled in an IVF cycle, and you're more likely to have a miscarriage. But you're not less likely to get pregnant. So there's no difference in pregnancy rates. This is somebody with a BMI of 40. So what happens is that we've got other conditions which we treat, but they're non-modifiable. So like, I know that you said we were going to come into age, and of course we've come into age. Okay? So somebody who's got a BMI of 40 versus somebody who's got an age of 40. Okay? Guess what? No difference in the days. Look at the pregnancy rate. Much, much lower. So if you're going to want to say, can I become pregnant with IVF funded by the NHS, you'd much rather treat a BMI of 40 for pregnancy than you would somebody who's age 40. Okay? Somebody who's 24 with a BMI of 40. But that's not why we do it. We do it because of risks to the mother. Because if you've got this modifiable thing, it's risky. And we've already heard, you're more likely to die, you're more likely to get preeclampsia, you're more likely to get gestational diabetes, you're more likely to get venous thromboembolism, and you're more likely to need a cesarean section. These are all bad things that are going to happen to the mother. But when you're 40 or above, bad things happen to mothers as well. Okay? And the biggest problem is, and the thing that I see as a clinician, is people are saying, I can't treat you with IVF because you're too weight. And then they come back to me and they said, Dr. Duncan, after 10 years, I've managed to get my weight down to BMI under 30. And I say, that now means you're 41. Okay, and that means that your risks were way higher than it was 10 years ago, and you won't get the same amount of treatment. And that's so depressing for me. And then obviously, what about the risks to the baby? And the risks to the baby, again, lots of risks to the baby, but risks to the baby in people that we do treat because they've got this non-modifiable risk. But the question is, how much is obesity modifiable, and what can we do to help? Now, here's the clinic that was done in Australia, and this was in women who weren't really ovulating. They were PCOS, and they called it the Fertility Fitness Clinic. Okay, and they got all their people with obesity and said, look, come to the Fertility Fitness Clinic. And what they did was they saw them at weekly meetings for 2 to 2.5 hours. And in these meetings, they did exercise, they did guided exercise, they talked about good eating, they did psychological interventions, the best possible intervention for obesity. And what happened was they didn't randomize it. Some people come along and said, right, I am going to do this. And some people went and went, oh no, that sounds like that. So what they did was they compared the people that did it with the people that didn't do it. And the bottom line about it is that the body mass index was pretty much the same, averaging 36, 37. Okay? And this is what happened. The people who completed it got their body mass index down. Okay? And they managed to sort of have some ovulations, have some pregnancies, and the people that didn't complete it didn't get pregnant at all. Okay, didn't ovulate, didn't get pregnant. And actually, all of the people that did that were still obese. You know, all of the people that succeeded were still obese, And the BMI after intervention had gone from 37 to 33.7. Okay, and they had about 10 kilograms of weight loss by that intensive measure. And that made a big difference. So there is no doubt about it that if you've got polycystic ovary syndrome and you lose weight, your fertility improves. And it's not just your fertility improves. Okay, here's another study that did pretty much the same thing. And what they found was their weight went down, their blood pressure went down, their glucose get better, their testosterone get better, their well-being get better, and they were more likely to get pregnant. Okay, so that's great. So weight loss through an intensive diet makes a big, big difference if you have polycystic ovary syndrome. But what about the people who sort of are obese and are not in that classic thing, or maybe they're obese at a BMI of 33 or 34, which is what these people have got to? What happens if we do weight loss before IVF? Because the whole point of weight loss is that things are going to be better. You've lost weight, your risks are going to fall away. But people with obesity are not the same as people without. It's a chronic, relapsing health condition that's associated with bad things. So here we are. Here's a randomized trial to weight loss intervention. And what you can see is that this is where I'm going to show you the results. And this is what happened. Whoa, fantastic. Weight has gone down a really decent amount in the people that we got the weight loss to do. So these people lost weight and then they did IVF, and the other people did IVF without losing weight. Okay? And the bottom line is that you might not be able to read it. An intensive weight reduction program resulted in a large weight loss, but did not affect live birth rates in obese women scheduled for IVF. So we're doing it, we're not seeing any benefits in the birth rates. But what happens if that's just one study. What happens if you do the meta-analysis of looking at weight loss treatment before IVF, comparing it to people who didn't have weight loss before IVF? And what you can see is that no benefit. And if anything, the hint's the wrong way. Okay? So what you can see is that if you're looking at having a baby, then actually, if you're going to do IVF, there's not any difference, and you don't get it's not any better having lost weight before it. And the other one to say is that yes, but all of a sudden these bad outcomes going to happen. Well, obviously the bad outcomes sort of don't happen. This one, again, you're taking your BMI, you're comparing a BMI of 29.9 to 33.2. So they're not in the extreme levels that we talked about before. And it took, I mean, this is only small numbers. There was only 317 people randomized, but they couldn't find any differences. They couldn't find that weight loss made things better for the outcome of the women and the babies. It might be if they'd done it with 1,000 people or 2,000 people to see it. But that's a lot of people to intervene with and not see any benefits at all. And this is a study from Australia where they thought, let's do a trial in these people who hadn't got pregnant, who were a bit overweight. Let's get them to really lose their weight, and we'll start them sort of on the 21 of the cycle. So they're starting them actually pretty much just before they start the IVF. They're going to say, let's lose some weight. And they've only got 3 patients that have done that to. And here at the top is what happened in the past cycle, number of eggs, fertilized eggs, and transferred eggs, okay? Then they had 27 days, 28 days in a diet. This is rapid loss. They're losing, between 2 and 6 kilograms rapidly. And then the outcomes, no fertilization, and one of them get no oocytes. So rapid weight loss before a cycle. If you say you have to lose weight really quickly before you do IVF, that makes IVF worse, okay? So I think that the conclusion, I want to be a little bit controversial, but I think it's probably important to bring that up. I mean, my conclusion is not from me, it's from 2 sort of titans of reproductive biology evidence base, okay? Ben Moll and Bob Norman. And what they're saying is, there is no compelling evidence of the value of lifestyle intervention for weight loss on live birth rates from well-conducted studies. Whoops. The research and medical and ethical opinions may now favour moving to fertility treatment earlier than originally recommended for patients who are overweight or obese, to make sure that you're not treating them as they're getting older and older and older, knowing that these women are different and they're riskier. and weight and age can be challenging if they don't lose the weight. But the sad reality is that now, if they've got any money at all, they're getting pregnant, but not through the NHS, because they're going to private clinics and taking drugs that are unregulated because I can't prescribe them for them.
You mentioned that if you don't lose weight, or that people are going overseas and being prescribed things that you can't prescribe, but if they don't lose weight, they can't access NHS treatment. So yeah, they're going to get older, and yes, they're going to go abroad. So it's a catch-22. What do we do?
I think that's absolutely right. But people are not needing to go overseas. You know, I would say a lot of patients, just like Rebecca, are going to a pharmacy or the internet and getting their drugs there. And certainly the weight restrictions for IVF are totally different in the private sector than they are in the NHS. So when it comes down to overseas and fertility tourism, it's often a cost-based thing or an access to donor gamete-based thing. But mostly it's when it comes down to weight loss medication and access to IVF, then the UK can provide that, whether or not it's done through the NHS or not.
I was actually just thinking about what are then the interventions clinic-wise for women who are obese and they become pregnant, but it's not a planned pregnancy, so they haven't been trying to become pregnant. And then what's kind of the course of action in that case?
I guess most or many women with obesity and diabetes will have an unplanned pregnancy. In an ideal world, you would want to see these women for pre-pregnancy counselling so that you can optimise their pregnancy outcomes. But I guess depending on the situation, we want to see them early on. You want to see them in early pregnancy, make sure that they've got a viable pregnancy, and then start the lifestyle advice and give them dietary advice. You might want to do early testing, get an HbA1c done if you think that, to try and identify those with pre-existing diabetes that haven't been diagnosed. We know that around 3% of women with pre-existing diabetes will be diagnosed in pregnancy because they've not been diagnosed, and then thereafter you will, if they're diagnosed with diabetes, they'll come into a combined multidisciplinary a diabetes antenatal clinic and have their care through there. If they're not, they will have pregnancy care. They will have a screening test. They'll have their scan at 12 weeks. They'll have a scan at 20 weeks looking for fetal conditions, and then they'll have regular antenatal care looking for the complications, whether it be fetal growth restriction, hypertension in pregnancy, preeclampsia. We'll offer these women additional scans later in pregnancy, and we'll discuss at some point their options for labour and birth, whether they have a birth by planned caesarean or they want to have a birth in a community unit at the other end, and we'll support their birth choices. And then once the baby's born, we'll plan their care afterwards in terms of improving their health outcomes in future pregnancy, but also improving their health outcomes in the longer term. So we'll have a package of care that's individualised to the woman, even if she does present with an unplanned pregnancy.
I can imagine that it's, for example, in terms of like the calorie intake, it might be a bit different compared to having someone who's planning a pregnancy and they'll have like a few hundred calories deficit, ideally for losing weight, and then for a pregnant woman, like I'm assuming because of the nutrition to the fetus, like you don't want to be restricting that too much. So is there like a balance in that? Yeah,
and so as I said, the average recommended weight gain for someone with a normal body mass index is in the order of 10 to 16 kilograms or so. For women with a high BMI, you want to limit that to about 5 to 9 kilograms or so. So you don't want to lose weight, but you don't want to gain excessive weight. You want to limit that weight gain in pregnancy with a view to optimizing their health during pregnancy.
Yeah. Sorry, I just have another question, just last question. Just had a question about, more about the diabetes and pregnancy. I was thinking if there are any kind of studies or clinical trials which would potentially, for example, look at patients who have insulin resistance or have pre-diabetic stage, then they try to make interventions to possibly halt the full onset of diabetes. Does it kind of get them to the point of a normal patient who's not diabetic, if that makes sense in terms of like fertility outcomes, or are they still at like a disadvantage because of maybe like hormonal or like metabolic changes or something?
Yeah, I'm not sure I'm quite getting the question, but we know that we can intervene in women to try and improve their insulin sensitivity by changing their diet. So there's been various studies done on things like following a Mediterranean diet, which is when you have a much more fish and lean meat and oils and vegetables. And they've done that in women, mainly in the postpartum period, in order to prevent risk of future diabetes. And then also there's been various investigation using drugs that can improve insulin sensitivity, so particularly the drug metformin. And again, drug trials that have been done during pregnancy when metformin has been given haven't actually shown any difference. But there is some evidence that if you take metformin, then you can prevent the onset of diabetes. But generally, people don't want to take tablets unless they have to.
Hello, I'm an IVF doctor, and I definitely see what you talk about with regard to women taking weight loss injections to bring their BMI down to fulfill criteria for NHS funding. We're seeing that really commonly because it's cheaper to buy the injections than it is to pay for the IVF. But slightly incongruously, as I am here, I actually live and work in Devon, and we have a very unusual requirement in that our ICB actually asks for the male partner to also have a BMI of under 30, even with a normal semen analysis. And I was interested to know if there's any emerging evidence on weight loss medication and semen parameters, or indeed IVF outcomes.
That's a very good question. And the answer to that is there's very good evidence of male obesity affecting sperm count and sperm function, but there's not any evidence that I'm aware of the use of weight loss injections improving male fertility. But the absence of evidence doesn't necessarily mean that there isn't anything with regards to that. I mean, certainly the question is, what is the mechanism? And I know that that when you have got lots of subcutaneous fat, testosterone can be changed into estrogen, and that will lower down your hormones that are driving spermatogenesis, and therefore what happens is that sometimes there are some medications that might improve things in obese people without weight loss. But I think that it's a very good question and a study that needs to be done.
I know there's a lot of noise around men reducing their alcohol consumption before conception. I think like not drinking at all for like 3 months, there was a lot of noise about that. And I guess like a follow-on from the previous question about whether BMI or type 2 diabetes or even smoking, if that has any impact on like the quality of like, IVF or like stuff like that.
Yeah, there's no doubt about it that's, particularly with regards to sort of male semen analysis, there is effects on smoking and there are effects on alcohol. And the reason about 3 months is it takes at least 120 days to make the sperm that you're seeing. When it's produced, it's already being made for that length of time. Now, the big question is, does that have big impacts on natural fertility? And does it have big impacts on the outcome of IVF? Because what you're often doing is, in the absence of extreme effects, you're affecting something which ends up still being in the normal range. But there are big studies suggest that there is actual impact on success rates for IVF and actual impacts but the effects on natural fertility are harder to work out.
So you don't think that like this hype will be put into like practice in terms of like suggesting and making like men aware of? Okay,
so obviously I do lots of fertility clinics, and we talk about healthy lifestyles in detail, and fertility clinics involve both the partners, and we're talking to the men and the women about that, and that's not. But when it comes down to weight loss management, we're lucky in the fact we've got some short-term funding for fertility-based weight management dietitians, but they don't see the men.
I suppose because of women seeking fertility treatment but maybe find that they're being blocked because of their BMI, might have kind of that additional drive to lose weight. I suppose the danger there maybe is that some women develop kind of obsessive eating habits or disordered eating, or obsession with exercise. I was wondering kind of whether you have any anecdotal kind of experience of that in clinics, and also how we can kind of best approach advising weight loss, kind of bearing in mind the danger of disordered eating, especially when you're kind of driven by seeking IVF treatment.
So in our clinic where we see women with a BMI of over 40, we have a specialised dietitian, and when we first opened the clinic we did some questionnaires with women about their eating behaviours, and there was a very, very high prevalence of disordered eating. And I guess, you know, if you're only 20 and you've already got a BMI of over 40, that suggests that there has been a problem. And as Colin said, it's not a problem that's just suddenly arisen, it's gone on for some time. I personally haven't seen in our clinic much evidence of it going the other way. We've only had one woman out of all the women that have come to the clinic since 2008 who did clearly have a very complex eating disorder, because came back to the clinic and had lost, you know, she had a BMI of like 18, having had a BMI of 50. I don't know whether anyone else has experience of that.
I mean, I think that I do see a lot of women with polycystic ovary syndrome who struggle with living with obesity, and the prevalence of eating disorders in that group are very, very high, regardless of whether or not they have to lose weight with regards to obesity. And I think it's a very, very challenging thing to do, and the use of specialised dietitians and guidance is all we can do, and the funding for that really needs to be embedded rather than ad hoc.
I was just wondering how diabetes or obesity can impact babies neonatally, and if it can also impact the baby's growth as well.
I guess both diabetes and obesity can impact the outcome for the baby in a number of different ways. I think both of those are associated with preterm birth. And preterm birth, the gestation at which you're born, can significantly impact the outcome for the baby. In terms of the main problems for babies that are born preterm relate to the lungs not being mature enough. And we try to prevent complications by giving the mum a drug called steroids. And giving the mum steroids can prevent respiratory morbidity in the preterm baby. But you have to be careful, because in women with diabetes, this will increase their insulin requirements, and you can, if you're not careful, tip them over into diabetic ketoacidosis if you don't regulate their insulin. So you have to up their insulin requirements for them. In terms of other complications that we see in babies that are born as a result of in women with obesity or diabetes, that are increased risk of other complications, such as hypoglycemia. I mentioned that these babies are going through pregnancy in a hyperglycemic environment, so they're secreting lots of insulin to try and adapt to that, and as a consequence of that, when they're born, they're taken out of that environment, they're still secreting those high amounts of insulin, so their sugar levels drop. Diabetes in the mother can also have an effect on the baby's liver, and can affect red blood cell production. So these babies need to clear those red blood cells, and they're more likely to get jaundice as bilirubin builds up as a byproduct of that, and that can lead to complications in the baby. These are the sort of main complications that we see. In terms of size of the baby, most women, insulin is an anabolic hormone, so the babies will secrete lots of insulin to try and regulate their sugar levels, and they tend to be bigger. That's the mechanism why these babies are bigger. So a macrosomic baby is a large baby, a big baby, and so women with obesity and diabetes tend to have bigger babies. But as I mentioned, if you've got placental dysfunction in association with either obesity or diabetes, then you might have the opposite effect. You might have a small baby, and so it can affect different individuals in different ways, and different babies in different ways.